hello everyone. We are now going to the industry symposium of today together and highlighting what will happen today. Jerry, tell us about your points.
So today there are some very interesting symposia at lunchtime, and we're all going to talk a little bit about, I suppose, the areas that interest us. SY1702 is a Becton Dickinson or BARD symposium on iliofemoral deep vein thrombosis, which is something dear to my heart. And we've got some young and exciting guns. We got Romeric Lefroy, who's from Dijon, and he's going to talk about ability in acute DVT practice. Then there's a session on PMAX, which is the trial using the Aspirex rotational thrombectomy device. And then there's a recorded live case on a chronic iliofemoral venous reconstruction. And then finally, I'm going to talk a little bit about the vernacular trial, so which was the 3-year data that Michael Dake presented yesterday as first at CIRSE. And we're just going to rehash those results, which are, in fairness, quite impressive. So that's the first one that I think is cool. And then personally, there's a symposium on the SY1803, the Boston Scientific one, which is kind of near and dear to my heart, and that's because it's highlighting the Galway experience, where I'm from. And I suppose over the last 20, 25 years, we've built up a method of working really closely together between oncology, palliative care, hematology, interventional radiology, vascular surgery. And specifically, we're focusing today on the acute iliofemoral DVT and venous thrombosis in cancer patients. Because cancer patients, as you know well, there's a risk that people can sort of say, oh, he's got a swollen arm or a swollen leg, he's got cancer, it's lymphedema, let's leave it alone. Yeah. But actually, most of these patients don't have lymphedema unless they've had an axillary lymph node dissection or a groin node dissection. Most of them just have a tumor or a lymph node or radiation fibrosis compressing the vein. Yeah. And they end up with a really swollen leg, and that leg dramatically affects their quality of life. So they've got this big heavy leg, they've got to drag it around, they can't get into their car, they can't go shopping, they can't live life. And we found that it really affects their quality of life. And so there are interventional perspectives on that and what we can do. But the interesting thing about this symposium, from my point of view, is that I've managed to get my oncologist and my palliative care doctors to come in and give how they see things. Because there's not a lot of point preaching to the converted, as it were. Like, I would hope that most people in interventional radiology, are happy enough to take on a swollen leg, a big deep vein thrombosis. I know you three gentlemen certainly are. But the key thing is to get the oncologists and palliative care team who are in your hospital to see that you can do this and that you can offer their patients this service. And I hope that comes home. We've got an interview with a patient's family, a little girl that I treated a few years ago. And that's, I think it's powerful. I think you might watch it. It's emotional. And I think you need to hear the impact that something which sometimes medical people, I wouldn't say trivialize, but don't afford it the respect that is due. Like, a swollen leg for a young child is a disaster. They can't run around the playground. They can't play. They can't do things the kids do. They can't, And so once we fixed that, it made a big difference to that little girl's life. And so that's my Tuppence worth.
I think, Jerry, you're right. You're underestimating the venous disasters, especially in cancer.
I think it is an issue because obviously venous thromboembolism and cancer are so tightly linked, and we've seen an even bigger surge, obviously, with COVID. But over the years, we've treated patients who I think in probably a lot of other hospitals are just kind of given stockings and anticoagulation, and in my opinion, undertreated, because either their length of life that is estimated to be left is too short, or people feel they're too sick. But we've had kind of extraordinary results, not because of me. I mean, I'm talking about, the oncology team assesses the patient, the palliative care get involved, they refer them to us, we look at them together, then we treat them. And the treatment is straightforward. It's simple. It's something that every interventional radiologist can do. And the benefit for the patient can be massive.
I think that's the message.
Yeah.
We can do it.
Yeah, we can do it. Easy. The question is to get your oncologist and palliative care and hematology to see that you can do it.
And to think about this.
To think about it. To consider it at least, yeah.
I think this symposium about this.
It should be interesting, yeah.
And it will be interactive anyway. People can ask questions.
It is, exactly that. And that's one of the things we've learned certainly in the last couple of days because of CIRSE 2021, the summit. It's so interactive that you can type your questions and they are getting answered in real time. And some of the questions are hard. Some of them are asking the question you don't want to get asked, you know. It's like, I was hoping nobody'd ask me that. But that's what it's about because, and that's what we're going to see again next year when we're live and together in Lisbon. You're going to have that intense interaction that makes CIRSE so special.
You make it so exciting. You want to see them all. You want to see them all.
My problem is I want to see all. I love this conference, and there's so many different things you want to see. There aren't enough hours in the day, and I suppose that's where the on-demand thing comes in, that you can go back and look at stuff because there's a long winter ahead of us, and there's lots of stuff to look at.
Thank you so much, Jerry. Thank you so much. I'm turning to Bellarmino now.
Hello.
Please, Bellarmino, tell us about the symposium.
We'll have first a Medtronic symposium. So we'll focus mainly on arteriovenous fistula. So, of course, the new devices, now we have another brand doing it. So we have we can do a percutaneous AV fistula creation, which is very important and very, with a strong innovation.
Very invasive, yes.
On this field of dialysis shunts. Of course, they will propose also an algorithm of care, trying to do it in a multidisciplinary approach. Everyone benefits, the nephrologist, the IR, the clinician. So it's perfect that they give this opinion about these new devices. And finalizing this symposium, we will talk about the drug-coated balloons that we are using more and more, especially in this field. You have sometimes you have more evidence on this field than in PAD.
Yes.
And of course, to achieve the best patency rates during the following years. Then, after this symposium, Gore and Associates will talk about this, the same subject, especially in the cephalic arch, relapsing stenosis. It's quite frequent, that stenosis. And then for arterial disease, how to manage with the grafts, the iliac occlusive arterial disease. It's also important. But of course, Gore will talk always about his Viatoris tips stent, doing a proper management in the variceal bleeding. Of course, is the most emergent and important thing about doing the tips. But doing it smaller than before. How this improves the survival? Doing the tips with less caliber,
I see,
and earlier than before.
Exciting, exciting.
Yes. So I think this for patients is quite beneficial, and we will prove for sure survival outcomes.
Great. And again, it will be interactive and people can ask questions. That's an everyday job we are doing in interventional radiology. I think that will be very exciting.
Yes, this is very important for patients.
Thank you so much, Bellarmino. Now, we have Mo with us, the scientific leader of ideas. Please tell us about the symposium you are looking for.
Well, there are several options available in this day, and I'll probably start with the first one, which is the prostate artery embolization technical challenges. And we all know that the prostate patients are frequently elderly, they are frequently atherosclerotic, and the access is an issue in several patients. Obviously, planning helps a lot to decide which angle of the C-arm and how to approach each branch and on each side, and also access whether radial or femoral. But beyond that, we need also to understand what is the best setting of equipment that we choose, because this will shorten the procedure time, this will improve the radiation protection to the patient and to the operator. And the the difficulty, there are so many options, and this is important to understand the pros and cons of each microcatheter and microwire. And I discovered the magic of Asahi technology in the peripheral, but with several wires, and each one has its role and benefits. But this also extended to the prostate territory. So we will hear about the various wires that can help the cannulation and navigating through those difficult vessels, and what combination of microcatheters and some lessons learned. So I'm really looking forward to that. There is another symposium about the day case service. This is a very close topic to my heart. It's a hot topic currently, at least in UK. CIRSE has done quite a good job about the ambulatory service, but we still need to know more. We all agree that the day case is fantastic for the patient, the quality of life of patients, experience. It's great for the workflow. It is great for the hospitals because you are relieving the bed pressure. But how to do it? Is it cost effective? We all say yes, cost effective, but we need to see what's the evidence for the cost effectiveness, because that's what you need when you go and negotiate with higher management.
Absolutely.
And talking about higher management, it is the main obstacle because it is cultural change, and people tend not to accept that or tend to resist it, at least at the beginning. So it's an uphill walk, and to do it, you need to understand why I'm doing it, how should I do it, what's the evidence behind it, what is evidence lacking, and we need to build it up. So all these hopefully will be discussed in this symposium. I'm grateful to Terumo to sponsor that. Finally, it's the symposium about the endovascular stent grafts in the TVAR and also in the iliac branch, which is sponsored by Gore. In this symposium, there will be discussion about the latest generations of the stent grafts from Gore. We all know that this field continues to develop both the evidence, the knowledge, and the technology. And it's crucial to appraise those technology. We need to know when this new stent is coming, what's behind it, what's the data behind it. I can't just use it because it's a new toy. That's not a good excuse. And in this symposium, there will be discussion about the evidence available about the conformability of those stents and their effect on the long-term durability. There will be discussion about the data available so far and the radial force of the stent and the conformability and the distal landing zone, how this will affect the chronic dissections. And also the precise deployment and how that is affecting the initial results and the long-term results. There will be also a discussion about the branch iliac. There are, again, several devices available at the market, and we need to know what the role of each one and what's the data behind it and what are the lessons learned from the experts, where I should choose this and that, or neither of them or both of them can be available. And hopefully this will be a discussion that enrich the knowledge of the audience.
Looks like really exciting. You know, that's the problem is in which one you want to be. You cannot be in all of them. That's really
the candy store.
Yeah, exactly.
A bit of everything. Yeah, I think the day case one. I think that's really, really important. I mean, they're all good, but I think for interventional radiology, day case is critical because the pressure on beds in my country and probably in everyone else's country is catastrophic. And interventional radiology offers patients the opportunity to have, cutting-edge procedures performed on a day case basis, go home, and it takes the pressure off the hospital. And I agree with Mo. It's incredibly difficult to get management to buy into this, even though it seems absolutely self-evident to us. It's like no beds, procedure done, patients, outcome is better. What can't you get?
One missing thing, data. We need a lot of data.
Absolutely, agree.
Well, that's it.
Like usual, evidence, evidence. I think is important. Very exciting day. And I will finish, if you allow me, with the Boston Scientific Symposium explaining cryoablation. I think this is an important subject of local treatment and focal treatment of metastases. A few years ago, when a patient was metastatic, we were telling, okay, it's finished. Nowadays, we have so many treatments to propose them: association, multidisciplinary, oncological treatment, focal ablation, embolizations. That's essential to talk about this and expand and to help the patient. As you said before, like thrombosis of the veins, people are underestimating what we can do in meds.
Yeah, you can do a lot with it. And the new cryo stuff from Boston is very impressive.
Absolutely.
The results are,
especially in the field of the new oligometastatic disease.
Exactly.
Starting and growing
Exactly.
every year.
And again, evidence to prove that quality of life of those patients, survival are better if we are selecting the best patients. I think that's the point.
Selection is key. Yeah.
Selection is absolutely key. And that will be interactive again.
Yeah, exactly. So, I mean, the typical questions, having done these before, is that people are saying, I have a patient with, say, colon cancer, 3 centimeter metastasis, 2 centimeter margin, what should I do? And that's the kind of question, because and you ask the experts, they're going to give you, they'll have seen that 100 times before. And that's the big advantage of the interactive.
And again, you know what I mean, and we are not looking just with one technique.
No.
We are looking in the
Lots
panel of different technology, medical treatment, radiotherapy, embolizations, all together to help those patients. I think in cancer, what we learn is not one technique is enough.
No, you can offer lots of different angles to kill it.
And how to make the best synchronization with our treatment.
Absolutely.
That's the key. Yeah.
Absolutely.
It's difficult, it's not proved yet.
Yes.
But we need to find out it.
Absolutely, that's it. That's,
fine-tuning.
as we said before, we need to remind our colleagues that what we can do, and that's why, being present in the multidisciplinary team, it's key. We have to sit there. Presence of us in those
the
meetings.
MDTs are essential, because if you don't pop up every now and again and say, well, that patient would do quite well with cryoablation or RFA or embolization or IRT or whatever, they will tend to forget, because we all tend to think in silos. The oncologists are thinking about chemo, and the radiotherapists are thinking about radiotherapy. And,
everybody looks from their windows.
Silo,
Exactly. And, everybody looks through a window and they see what they have in front of them.
That's right. Whereas we need to pop up and
exactly.
make sure
and,
our voice is
clinical
heard.
patients care, and again, see them in the office before. You think on the images the metastasis is feasible, then you see the patients, that this is not
an
feasible.
option. No, exactly. And that's key, to see them before and longitudinally, and offer really appropriate risks and benefits. And you have to see the patient. You're so right, because you're presented patients, this patient might do well, say, for cryoablation, then you meet the patient, they're underweight, they're not eating, they've got no social support, they're diabetic or whatever, and you're like, maybe not.
I will not do any good to the patient.
No, I'm not going to help the patient here.
Exactly.
That's the key, because interventional radiology is a clinical specialty, and that's key that we see the patients before, during, and after.
Absolutely, that's the message. And we are counting on you to be interactive. We want you to ask questions. Don't be shy. You can write any question, and as we have insisted now, we will answer to them, and that's an exchange. Thank you very much.